Yeah, good evening, everybody. Welcome to this evening interesting session of an insight about immediate dental implants by Honorable, Respectable, and Knowledgeable Dr. Kapil Singhal. Dr. Kapil Singhal is MDS from Government Dental College, Jaipur, and his specialization has been in implantology and periodontology. And Dr. Kapil Singhal has also had global training in soft tissue and hard tissue grafting, zygomatic dental implants, and conventional dental implants. He has his own private practice at Jaipur with the name of Ekdantam with in-house CAD/CAM facility and intranasal and lab scanners. I'm sure you will be able to enjoy this evening, and thank you for joining us this evening. Over to you, Dr. Singhal, to take it forward. Thank you very much.
Thank you so much, sir. And I really thank Microlabs for giving me an opportunity to speak with the doctors about the topic that is a very important topic, I believe, in implant dentistry, immediate dental implants. So I believe implants in post-extraction sockets has always been very challenging, and because that does not provide very good stability. It's quite wide, and you need to place the implant in a correct position, three-dimensionally. That should be prosthetically correct. And also, it is very important that the that while placing the implant, you get a good primary stability. So there has been a lot of terminologies that has been used for implants in post extraction socket. Initially, the people like Wilson and Weber, they classified it as immediate, recent, delayed, mature. Immediate is just during the time of extraction. We are extracting the tooth and we are placing the implant. Recent is when the soft tissue healing has occurred around at the period of 6 to 8 weeks after extraction, the implant is placed. And delayed is when there is a period when some amount of hard tissue formation has also occurred, and the implant placement is done around a period of after 3 to 4 months. And mature, when the bone is completely mature, it means the woven bone has converted to lamellar bone after a period of around 6 months when an implant is placed. That is the mature bone. After this, also a lot of classifications were given by a lot of people. A terminology known as early implant placement was given by Chen and co-workers, which also means that once the soft tissue healing has occurred, after 6 to 8 weeks, the implant is placed. So during my complete presentation, my focus would be mainly on the type of implants, that is the immediate dental implants. And I would even tell you in which cases you should go for immediate implant and in which cases you should avoid placing immediate implants. Okay. So the classification that I personally follow for implants in post extraction socket. So see, implants in post extraction socket can be placed immediately also, or at some intervals of time. So based on this some intervals of time, this implants in post extraction socket has been classified by Hammerley and co-workers in 4 types. See, this is very important. 4 types. Type 1 is immediate placement, means we extract the tooth and we place the implant at the same time. That is the immediate placement of implant. Then comes the type 2 placement. So in some of the cases, we want a good amount of soft tissue also. So what we do, we extract the tooth and we wait for 4 to 8 weeks for the soft tissue to heal. Okay, so after 4 to 8 weeks, when we get a good soft tissue closure and soft tissue has healed, when we place implants, now this comes in type 2. Type 3 is when we want the soft tissue to heal and also some amount of bone formation to or also occur. Means some amount of woven bone formation also starts. Okay, so this is type 3. And type 4, when there is complete mature bone formation, means you extract the tooth and you will wait for a period of 6 months or more, and then you will place the implant. So that is type 1, type 2, type 3, and type 4. So my focus today, my webinar, my presentation today will focus on type 1 implant placement. Okay. Now, what is a need for immediate implants? Previously, a lot of people, a lot of researchers have said that immediate implants are not very successful, but with long-term studies, a lot of longitudinal study, it has been seen that they have equivalent success rate or slightly lesser success rates as compared to the delayed implants. And believe me, it all depends upon how you place the implant, what is the correct three-dimensional position, how good prosthetically you place it, and how wisely you follow all the basics while placing the immediate dental implants. So see what happens as you extract the tooth. Okay, so always after extraction of tooth, there are some dimensional changes in the bone. Why? Because our tooth has periodontal ligament around it, and we all know that this periodontal ligament, it supplies blood to the nearby bone. So as you pull out the tooth, you remove the periodontal ligament also. It means the blood supply to the nearby bone also gets compromised. Okay, so it has been seen that Schropp and co-workers found out that there is 50% reduction in the width of the bone in a period of 12 months. Matlab, if we extract the tooth in a posterior region within a period of 12 months, there is 50% reduction in width. Okay, now see, we can see in this picture that the tooth has periodontal ligament around it, and on the facial side, the bone that is present is very thin, and it is mostly bundle bone. And on the palatal side, the bone is pretty thick. So it is very important that we take care of this facial bone, which is a very thin bundle bone. And I told you that as we pull out this tooth, the periodontal ligament comes out, and the blood vessel with the PDL also goes away. It means the blood supply of our bundle bone is compromised. So now implant placement in this condition is very tricky. Okay, now it means after pulling out our tooth, our socket is only lined by the soft tissue. Okay, so this soft tissue basically has a mucosa overlying and a periosteum below it. This periosteum also supplies bone to blood supply to our bone. So it means our bone, basically our bone is supplied by blood from the periodontal ligament and the periosteum on the outer side. So now we have pulled out the tooth. It means our bone will only be supplied by blood by the periosteum attached on the bone. Okay, so now suppose if we reflect the buccal of the facial flap, it means you have reflected the periosteum also, of the facial bone. It means now the blood supply of this thin facial bundle bone is completely compromised, and there are high chances that if this facial bone is very thin, it will get resorbed. So the first important thing that you have to remember while placing immediate implants, especially in interior region, is that you would never reflect the facial flap if you don't need to do any grafting and if it is not required, because you want this periosteum to be attached on the bone and provide blood supply to our facial bundle bone. Okay, now a question arises: immediate type 1 or a early placement type 2? Means do I place an implant immediately after extracting my tooth, or should I wait for 6 to 8 months? So it has been seen by Coheney and workers in 2004. They published a research paper and they found out that if you're placing an implant immediately, then the amount of bone width that you get is more as compared to early placement that you do after 6 to 8 weeks. So there was a difference of about 2 mm. Okay, so it is always good that if you can go for an immediate placement, it is far better as compared to an early placement. Now, also, I told you, as we extract the tooth, we have extracted this tooth, and I told you that facial bone is very thin and it is mainly composed of the bundle bone. So this bundle bone, you can see when this is a picture of a lower anteriors. When we extract the lower anteriors, so the lower socket something looks like this. Okay, and if you will not do anything in this socket, after a couple of months, what you will see is just a thin bone, thin one shelf of bone that is not good enough even for implant placement. Then you have to do some grafting. So what is advisable in this case, that you ideally place the implant, and if required, do the grafting at the same time to prevent this bundle bone loss. Okay, so this bundle bone is very important to be protected. And how would you protect it? By immediate placement and not reflecting the buccal flap. Okay, also what happens as you pull out this tooth, there is some osteoclastic activity on the external side of the bone. So whenever you pull out this tooth, there is some osteoclastic activity on the external side of this bone that further resorbs this bone and reduces its thickness. Okay, so now it gets very important that as you are pulling out this tooth, and if the socket is fresh, if you are placing an implant at the same time and grafting it, you are basically slowing this procedure, and still you are getting a volume to place the implant in the socket. Suppose there is a socket, that socket has a volume in which you can place the implant three-dimensionally, and otherwise if you would have planned an implant after a period of 2 to 3 months, so the volume of the bone buccolingually has reduced, and now placing becomes more challenging and would require more grafting and more skills. Okay, so due to this resorption of the plate, due to this facial bone resorption, there is a reduction in horizontal bone volume. Okay, and we all know our soft tissue basically rests over the bone. So with resorption of this bone, the soft tissue collapse will also occur. As you can see in this picture, the place where the tooth is present, the soft tissue volume is pretty good, and the place where there is loss of tooth, the bone and the soft tissue resting over it has also collapsed. Okay, same is seen in this picture. The soft tissue over the site where the extraction is done, the soft tissue has collapsed. So I would say that implants in a post extraction socket basically are a very good idea, especially in interiors. But there are some conditions where I would say not to place the implant at the same time. We would discuss it as the presentation goes, but if you could always place implants immediately, and if required, graft the site at the same time. So this will reduce the amount of collapse of the bone and the soft tissue. But implants in post extraction sockets requires a lot of things to be taken into account. Okay, the four important things that you should keep in mind is: number one, the patient itself. What are the expectations of the patient? What is the risk factor with the patient? Is he a smoker? Is he immunocompromised? Is there any other medical or dental risk that is accounted with the patient? Second, the treatment approach. What is the risk factors involved with the procedure? Whether this procedure is a high risk, moderate risk, or a low risk procedure. Okay, so you have to quantify. There are a lot of factors that you have to take into account to decide whether it is a medium risk, high risk, or a low risk procedure. Similarly, what biomaterials you have to use, means what implants, if what grafting is required, which graft and which membrane is required. And the most important, the skills and the judgment of the doctor itself. That is one of the most important thing. So there was a assessment given by Martin and co-workers, a very important assessment. They basically evaluated 12 criteria to decide whether placement of implant is high risk, medium risk, or low risk. So they called it as aesthetic risk assessment. static risk assessment, and they evaluated 12 criteria. Okay, so first was the medical status, that is the patient healthy or is his immune system compromised. Okay, then the smoking, is a person a smoker, is he smoking less than 10 cigarettes, it's a medium, and if it is he's smoking more than 10 cigarettes, he's a high risk patient. Similarly, what are the expectations of the patient? Sometimes we all get some patients that are, we want our teeth like this, and they have very high expectations. So we know from the very start that we have to take even very small intricacies in the patient, we have to take all those intricacies very wisely, and have to take care of all those things. Okay, so you have to categorize the patients as low, medium, high according to this also. Very important is the lip line. So when the patient smiles, okay, if you can see the transition line of the teeth and the gum, it means the patient is a high risk patient. It means the complete tooth is visible, and you cannot compromise with the aesthetics. Means if you need to get that balance of white and pink correctly, and you need to do some grafting or soft tissue surgery also, then you have to do it. So it is very important you evaluate all these things before starting the procedure, because once you have placed the implant, and after 3 months, when you have given the prosthesis and your patient is smiling, and you can see the pink of the tooth or a big dark triangle in your patient's mouth, then you cannot do anything. Okay, so very important that you evaluate this. Next is the tissue biotype. If you see your patient's soft tissue biotype, and if it is thick, it should bring a lot of smile on your face, because a thick biotype means the keratinized tissue is thicker, and a thick tissue takes care of the underlying tissues, whether it is an implant, the bone, the grafts, very well. So a thick biotype, even if you are placing an implant and a abutment, so this thick biotype will not get that hue of the titanium, and it will look more aesthetically better as compared to a thin biotype. Next, the tooth shape. If you see a patient with a squarish tooth shape, these are low risk patient. A patient with a triangular tooth shape, these are high risk patient, because generally it has been seen that patients with triangular tooth shape have thin biotype. Okay, so these are some important things that you can just evaluate when the patient walks into a clinic and sit on your chair. Okay, so before committing anything, just evaluate, is he a low risk, medium risk, or a high risk patient? Okay, now next is there any infection in the site? If you're placing an implant, it means that tooth is infected. So is there any infection, and acute or chronic? What type of infection is there? Okay, if there is an acute infection, you may need to first treat that acute infection. So you have to categorize the type of infection also and the risk involved. Next, a very important point, the distance of the crest of the bone to the contact point. Tarnow said if the distance of the bone, crest of the bone to the contact is less than 5 mm, then the interdental papilla generally completely covers it. But if this distance is more than 5 mm, there is some black triangle that is visible in between the CBCT also. You can just mark the point from the contact area to the crest of the bone and can check the distance. Okay, besides this, the other criterias are the width of the single tooth, the mesiodistal width. If the distance is more than the single tooth that you're replacing, it means you have to do some more aesthetic work on the adjacent teeth to get the proper size difference of all the teeth. Okay, then the soft tissue anatomy, if there is some soft tissue defect, some cleft on the soft tissue, that also needs to be addressed, and it becomes a high risk patient. And the last, the bone anatomy, if there is a bone defect, it becomes a high risk patient. And please remember, a vertical bone defect is more difficult to repair as compared to a horizontal bone defect. So a vertical bone defect becomes a high risk patient. Okay, next, a very important study was done by Vidrana Brot et al. And they basically checked the thickness of the facial bone. So see, they check the thickness of this facial bone. Okay, and they check this thickness at a distance of 4 mm from the crestal bone and at the mid root area. And they checked around 125 CBCTs and checked around 500 different teeth, anterior teeth, and they found out that in 65% cases, this bone, this facial bone, which I was telling you was very thin, which is made up of bundle bone, is this facial bone is less than 1 mm in thickness. This facial bone is less than 1 mm in thickness, and they even found out in around 25% people, this facial bone is not present in the crestal 4 mm. Okay, so they found out this facial bone is very thin in around 65% people, and around 25% people, this facial bone is absent in the crestal 4 mm of the bone. Okay, and in around 12 to 15%, this bone is more than 1 mm thick. It means that the thickness of this facial bone that should be more than 1 mm is very less, in less than 15%, and in most of the cases this thickness is very less. Okay, so one more very important classification was given by Howard Gluckman, and he classified the anterior tooth based on the presence of the tooth in the socket on the CBCT. Okay, so he classified it into class 1, class 2, class 3, class 4, and class 5. So this is a very practical classification when you are planning a implant case in anterior part of maxilla. Okay, a very important classification. So suppose it is a class 1 type. So in this, the root is basically positioned within the ridge. The root is well positioned within the ridge, and the facial bone is pretty thick. Okay, and class 2 is when the tooth is retroclined. Okay, the tooth is retroclined. It means when it will be retroclined, the thickness of the labial plate will reduce. Okay, and then he again classified it into class 2A and class 2B. So class 2A is retroclined in such a way that the crestal bone is thick, as you can see in this diagram, second diagram, and in class 2B the crestal bone is thinner. Okay, the class 3 is tooth is proclined. So if a tooth is proclined, the facial bone will become very thin and the palatal bone will become thicker. Okay, so in these are the cases in which if you are placing the implant, you have to graft on the buccal side also, so to support your buccal bone, to support your facial bone. And class 4 is when the tooth is positioned out of the bone envelope. So the bottom left, you can see the tooth is positioned out of the envelope. That is class 4. And class 5, when the bone is very thin, both the facial and the palatal bone walls are very thin, then it is class 5. Okay, so this is a very good practical classification when you are looking at a CBCT to decide what implant placement, where should be my implant placement, and do I need to graft or not. Okay, so even you can get these type of cases in which you can see that the tooth is resorbed and failing, and it due to the infection in the tooth, it has even resorbed the facial bone. The second slide on the right, I'll show you the complete case for this case, how we manage such type of cases if there is severe bone resorption like this. Okay, so now based on the different types that I have told you just before this slide, where should be the initial punch of your drill? Where should be the initial punch of your drill while placing the implant? Okay, so suppose it is a type class 1 type of socket. So the class 1 type of socket will basically start we can start drilling in the socket, but keep the drill slightly palatal. Don't keep the drill exactly in the center of the socket, otherwise you will end up you're placing the implant too labially. So if it is a class 2A type of socket, then you'll make a punch hole on the palatal wall, in 3 also palatal wall, and 4 also palatal wall. So ultimately, while placing the interior implant, the main aim is that your implant should not come in contact with the labial or the facial plate, and it should have a distance of around 1.5 to 2 mm away from the labial or the facial plate. Okay, now what are the advantages of different type of techniques that I have told you? I have told you type 1 implant placement in post extraction sockets, type 2, type 3. So what are the advantages of it? So Daniel Boozer, he said the main advantage, and we also know the main advantage is the time and the number of surgeries. If I am doing a type 1 implant placement that is immediate, obviously the time is totally reduced. We can give up prosthesis to a patient within a period of 2.5 to 3 months. And if you are doing, and just a surgery that is required is 1. And if you are going for a type 2 and type 3, the number of surgeries involved are 2, and the time period also increases to a longer period as compared to type 1. Okay, so now the question arises, do we need to graft our immediate implant cases or not? So it has been seen by a lot of researchers and lot of studies, and my personal experience, that if the tissue architecture is thick, and if the labial plate is more than 1 mm, then, and if you're placing the immediate simultaneously, there is no need to graft the side. Okay, so if the tissue architecture is thick, and if the labial plate or the facial plate is more than 1 mm, that I told you is seen in around 15% cases, then you need not to graft the side. But if the labial plate is thinner, less than 1 mm, then it is mandatory and very important to keep that facial bone and that bulk of bone, that you graft the side along with implant placement. So I'll show cases of both types as we progress. Okay. Okay, now a lot of times, see, whatever type of implant you're placing, whether you're placing an implant in a type 1 socket, or sorry, no, in a type 1 case or a type 2 case, means immediate or an implant after 6 to 8 weeks, there is some amount of horizontal bone loss that always occurs, because anyways you are compromising the blood supply because the PDL is removed. So some amount of bone loss will be there. So to compensate with that bone loss, sometimes, especially in cases when the tissue architecture is less, it is important to do a connective tissue graft. And this connective tissue graft can be done simultaneously with implant placement, or it can be done at a time before the prosthetic phase during stage 2. Okay, so to compensate for the bone loss that is occurring due to the tooth extraction and immediate implant placement, so compensate that bone loss, a connective tissue graft is a good way to maintain that bulk of soft tissue on the buccal side. Okay, now very important, this is a very common mistake that most of the people do, that they especially in incisors, they like to place bigger implants. Okay, so it is very important that we don't use oversized implants. It is not necessary to fill the complete socket of central incisor with a 5 or 5.5 mm wide implant. So if you are doing so, first of all, you are getting a poor emergence profile for your implant, and secondly, you are filling that complete socket with implant. Implant is a screw made up of titanium. You need bone around your implant so that your implant stays for the lifetime. Okay, so implant size of 3.5 to 4 mm is sufficient if you are going for an immediate implant in interiors. Okay, for me, my preferred size for incisors is mostly 3.5 to 4 mm. For lateral, always 3.5 mm. And if it is a canine, a 4 mm implant, that is what I prefer. I personally like more amount of bone. So I keep a safe distance of around 1.5 or 2 mm or 2.5 mm from my labial plate and implant. Okay, so please, no oversized implants for anteriors. Now, I'll tell you a very easy way how you should place anterior immediate implants. Okay, so a very simple way. Okay, so this is the post extraction socket, and I told you the palatal socket wall is pretty thick as compared to the facial socket wall. Okay, so for me, my immediate implant drilling, it starts at 100 RPM, and that too without saline. So this is the most important thing for a perfect placement that I believe. Okay, so your speed of your physio dispenser should not be more than 100 RPM, and there is no need to use saline if you're drilling at 100 RPM or lesser speed. Okay, so what is the advantage when you're drilling at such a slow speed? So advantage it that first of all you can control the drill to go in a perfect angulation. The drill don't slip, and secondly you collect a good amount of autologous graft while drilling. So what happens whenever I'm doing an immediate implant, I drill it at 100 RPM without saline, and I keep on collecting that graft that comes in my drill, and I mix it with my artificial graft, xenograft, or any graft that I'm using. So I'm getting some free graft that is of high value. Okay, so what I do is I use this side cutting drill. This is a very important drill for immediate placement. Whenever there is an immediate placement, the first drill that I use is this side cutting drill, and I use it at a very slow speed of 100 RPM and no saline. Okay, so I don't preferably place my drill directly in the center of the socket. So please don't do this. Why? Because if you are doing this, what will happen? The drill tries to slip in the area of least resistant in the tooth socket. Okay, so what happens, the socket is a very wide socket. It's a very wide area. So whenever you place the drill directly in the socket, the drill tries to slip in the area where the resistance is minimum. That is the where the tooth was present. So as you drill in that socket, the drill slips, and there are chances that you will perforate the labial plate, and you will come out of the socket, out of the labial plate. So never place the drill in the center of the socket and start drilling. And suppose the perforation does not happen, you're lucky enough that with God's grace that the perforation will not happen. What will happen? You will place the drill in the socket and you will place the implant. Your implant will be too labial, and there are high chances that it will touch the labial plate also, and over a period of time your labial plate will resolve. So if you are drilling exactly in the center, you'll come out placing your implant in the socket that is too labial, and the chances that your labial plate will resolve, and even the prosthetic planning will also be compromised. Okay, so first thing, never drill in the center of the socket. Okay, so see, the labial plate thickness has reduced to very less. Okay, so this is a very common mistake. You can see in the second picture, the sagittal section, the tooth is positioned like this, and if you place the implant in the same anatomy, the labial plate is very thin, and the implant will barely have any bone on the buccal side. So place the implant in a 3D correct position in the palatal. I'm not telling you to place it completely in the palatal wall. You should start with the palatal wall and come in the socket and graft the buccal side or the facial side if it is required. Okay, now a very important tip how to do it correctly. So I told you what not to do, and now what to do to put it in a correct way. Okay, so first thing, take your side cutting drill and place it on the palatal wall 4 to 5 mm away from the crest, and start drilling at 100 RPM without saline. And you need not to drill completely in the palatal bone, just make a punch of 0.5 mm in the palatal bone. So as you get this catch or punch in the palatal bone, now what you do, make this side cutting drill straight. Now you will make this side cutting drill straight while in a moving motion. Don't stop the footrest of your physio dispenser. Your drill should keep moving and you will make the drill straight. Okay, so this is how you position your drill on the palatal bone, and the drill should be placed 4 to 5 mm away from the crest of the bone on the palatal wall, and start drilling at 100 RPM. Okay, now make the drill straight and drill with respect to the palatal bone. Okay, so go above the tooth socket. go 2 to 3 mm above the tooth socket, because this 2 to 3 mm bone is the main bone that will give you and your implant the primary stability. Okay, so you need to drill 2 to 3 mm above the apex of the bone, above the apex of the tooth socket. That would provide you with the good primary stability. Okay, so this is the punch, this is the osteotomy that you have created with the side cutting drill. Now you should drill through this area interiorly in the socket. The one more mistake that you may make is that you start drilling completely in the palatal bone. If you do so, what will happen? Your palatal bone will become thin and you'll have a lot of labial or the buccal cantilever. So start drilling from this punch hole from the osteotomy that you have created into the socket. Okay, so I'll place my next pilot drill and I start drilling in the socket, and I'll place my implant. So make sure that your implant is at a distance from the labial plate. Means your implant should not touch the labial plate. If your implant is touching the labial plate, that pressure that implant creates on the labial plate will completely resorb it. And believe me, this is something that you will not see it at the time of implant placement. If you get a scan of such case done after 3 or 4 months, you will find no bone on the labial side. Okay, so now the question arises, do I need to graft on the in the distance between the implant and the facial bone? Do I need to graft it or not? So how would you decide this? So please remember, if the labial plate is less than 1 mm thick, it is always good that you graft this area. Okay, so if the labial plate, and how would you know that labial plate thickness is less than 1 mm? On a CBCT scan. So when you get a scan done for your interior case, see if the labial plate thickness is less than 1 mm. If it is so, always graft that area. Okay, now a case. Okay, so this was a case in which a central and a lateral incisor was broken in a road traffic accident a couple of years back. So we extracted the tooth. The thing that you should note in this, the tissue thicknesses biotype is good. Okay, so this is a good thing for me. But you can see a soft tissue defect here. Okay, so this is a point of concern for me. Okay, and the labial plate thickness was thin in this case, less than 1 mm in this case. So what I did, I extracted both the tooth and I didn't reflected the labial flap. I didn't reflected the labial flap. I placed a 4 by 15 mm implant in the central incisor and a 3.5 by 13 implant in my lateral incisor, and see the distance of my implant with the labial plate. There is a distance of around 1.5 to 2 mm, more than 2 mm, I guess. Okay, so this prevents any type of tension or any type of forces on my labial plate, and it will prevent it from resorbing. So this is a very important thing that every one of us should remember while placing implant in any of the interior region or a premolar region. Your implant should never be in contact with your labial plate. So I don't want to place an implant of 5 mm, 5.5 mm in my incisor and completely fill this socket with an implant. Okay, so this is an implant of 4 by 15 in central and 3.5 by 13. And as I told you that the facial bone thickness was less than 1 mm, so what I did, I grafted this side also. So I actually okay, I missed one slide. I collected the bone while drilling. So I collected the autologous bone while drilling, and I mixed it with the xenograft, and I just no membrane is required because my labial plate was there, just the labial plate thickness was less. So I just grafted that area in between the bone and the implant. Okay, and I sutured it. So this is 6-O-proline. I sutured it and I gave him a good Maryland because I want my implant and graft to rest in peace, to heal nicely. After this case, we did it last week only. So after couple of after 3 months, we would give him a provisional, a temporary, to get a proper soft tissue architecture. If it is required, we'll do a connective tissue graft also at that time. And then once the tissue architecture is achieved, then we'll give him the final prosthesis. Okay. Okay, next, this single slide is just to show you the distance of my implant with the buccal or the facial plate. Very important that you keep this jumping distance. Okay, a very good case. Around 24-year girl, epileptic patient, she came to me with an avulsed tooth, and that tooth has avulsed 4 or 5 days before, and she was carrying that tooth, but she came to me after 5 or 6 days after the tooth avulsion. So what we do, the socket was looking like this when she came to me. So this was the socket, and we place the implant of 3.5 to 14 in her. So the thing that you should see in this case is, first of all, the tissue architecture is good, it is very thick, and my implant is at a distance of around 2 from my buccal or the labial plate. My implant is at a distance of 2 okay. So what I did is, I had that avulsed tooth with me, which she gave me. I cleansed that tooth, I cut the root portion, and I make a opening on the lingual side of the tooth. Okay, and that opening is made in such a way that my abutment could easily fix over it. Okay, so what I did, I basically put the abutment in patient mouth, and I used the flowable composite to stick my tooth over that abutment, and I removed it, I polished it, I used the Soflex to smoothen it to get a proper architecture of this temporary immediate tooth. So this was the condition immediately after the implant placement and after the temporary was given. The patient came to me after 3 months, and we could see good amount of soft tissue healing in the patient. Okay, now the patient is ready for the final prosthesis. Okay, so now I need to make an impression for the final prosthesis. So this is the soft tissue architecture when I remove the temporary. See the bulk of the soft tissue and the soft tissue healing and the proper interdental papilla that I need for a perfect permanent prosthesis. Okay, so see the soft tissue bulk, it is exactly like the adjacent natural tooth. So this is the positions of interdental papilla after the temporary removal after 3 months. Okay, so what we did, we replicated the, we made a customized impression post. And how do we do it? We replicated that temporary. So we fixed the analog. In the first picture, we fixed the analog over our temporary prosthesis, and we took a putty impression of it. Then we removed the prosthesis with a hex driver, and in the final slide, you can see we get the impression of the tissue surface of the temporary. Okay, so this is how you duplicate, you make a putty index of your temporary crown. Okay, now what you will do, you will put a impression post over this putty and flow the composite around that area. So basically now you will get an impression post that is customized according to the tissue architecture of your patient that the temporary has created. Okay, so now in this slide I have fixed that open tray impression post in the patient mouth. Okay, so this is the customized impression post I fixed in patient's mouth, and we took the impression of the patient. So this is the open tray impression. Now we place the abutment in patient's mouth, put a retraction cord. This is a very good way. This prevents the excess cement to go into the sulcus area. So I'll just remove it before, after placement of my crown, to remove all the excess cement. Okay. One more thing that I generally do with my cement retained crown is I make a putty index, a silicone index for it. So I take my crown, I put some putty inside it, wait for it to set. So this is my silicone index to remove the excess cement. So what I do is, now I put some cement in my crown, and before putting this crown in my patient's mouth, I put this silicone index to remove the excess cement, because I just need a thin layer of cement around my prosthesis to stick it over my abutment. Okay, and this is how the crown look immediately after cementation. So this is how the crown look immediately after cementation. So see, so you can get a very good aesthetics if you're going for an immediate implant, because what I did is, as the patient came to me, I placed the implant and I gave the provisional that maintained the papillas and the soft tissue bulk over that area. Okay. Okay, so for upper anterior implants, I have told you what important things you have to remember. First of all, a drill with an angulation 5 to 6 mm below the crest of the bone at a slower speed of 100 rpm, and after you get a punch of 0.5 mm, make it straighter to drill with respect to the palatal bone in the socket. And the final position of the implant should be at least 1.5 to 2 mm away from the labial plate. So if your implant is touching the labial plate, see, this is what it would happen. The labial plate will completely resorb, and your implant, though stable, will have poor facial aesthetics. That there will be gingival recession, and this implant will have high chances that it could fail in future. So never place an implant touching the labial plate. Okay. So if you're placing an implant directly in the socket, this is what it will happen. Same picture, same play. Don't place the implant touching the labial plate. Place it with respect to the palatal plate in the socket. So this will also help you to get a good emergence profile for your prosthesis. Okay, these are the same slides that are telling that we should place from the palatal wall into the socket. So this is how you drill with the palatal bone, then keep on drilling in the socket, and the placement should be in a proper way. Okay, so after placing in such a way, if it is required, I told you, if you feel that the labial plate is thinner, even in cases of delayed implant, you need to graft the buccal or the labial side to get the proper bone around your implant. Okay, sometimes after placement of implant, it looks you have achieved good aesthetics, but when you get a CT scan done, see in this scan there is no bone on the labial side. So this is not a proper placement. There are high chances that this implant can fail in future. Okay, so this is the ideal angulation of implant placement. If it is too facial while drilling, means your drill head is too facial, the facial bone will become very thin. And if it is too palatal, then there are chances that you will perforate the facial bone. Okay, now how deep an implant should be placed, a very important point, how deep you should place the implant. So please remember that the implant should not be placed too deep, and it should be placed 2 mm below the CJ of the adjacent tooth. So the adjacent tooth cemento enamel junction is the guide, and from this CJ you should place your implant 2 mm below. Okay, so this is a placement. See the implant not touching the buccal or the labial plate, and the implant is 2 mm deep from the adjacent tooth cemento enamel junction. Okay, 2 mm below the adjacent in cemento enamel junction. Now always keep this jumping distance of 1.5 to 2 mm while placement of the implant. The same pictures depicting the jumping distance. Okay, so this was a case, the central incisor was fractured, vertically fractured. We removed the tooth, we curated the socket, and this was the tooth that was fractured. We used the drills to place with respect to the lingual plate, and we placed the implant. And I got a little bit less stability, so I didn't immediately loaded my implant. What I used the patient's tooth, and I used a fiber splint to use it as a temporary. Okay, so this is immediate temporary. I did give it with a fiber splint. Okay, so my depth of implant placement was 2 mm below the cemento enamel junction of the adjacent tooth. Another case, okay, a very important areas, and even some of the posterior cases, is a socket shield technique. I just want to show you what benefits you achieve when you're doing a socket shield technique. So in this case, the patient had missing both the central incisors. Okay, so one of the central incisor has a root stump and other one does not have, it was infected. So we plan to do a socket shield on one side and an immediate implant on the other side. Okay, so a socket shield on one side and an immediate. So just see the difference of the papilla. So see, on the socket shield side, the height of the interdental papilla is quite higher, around 3 to 4 higher as compared on the other side where we just did the immediate implant. So a socket shield is a very good technique, and wherever it is possible, where you can conserve that facial shield of tooth, preserve it, because what happens, the PDL fibers attached to that facial shield supplies blood supply to the facial bundle bone that I told you is very thin. So it maintains that bone and hence the interdental papilla. Okay, so same picture depicting the socket shield side having a higher interdental papilla as compared to a immediate implant. Okay, another case. Okay, so this patient had a trauma when the patient is around 45 years and he had a trauma when he was very young. So the patient's central incisor was fractured and the lateral incisors roots were resorbed. Okay, so these are the cases. I told you this case I would share. How would you deal with such cases? These are some advanced cases. In such cases, basically, I extracted the central incisor and lateral incisor and I planned a implant placement simultaneously with the GBR technique. So what I did, I extracted the tooth and I curated both the sockets with my curate, and to make sure that the bone is healthy, the bone is clearly visible, and I used a lot of saline irrigation to irrigate it. Okay, so while I am doing such type of cases, whether I have to do a immediate implant or not, how would I decide? So see, in this case, you can see I have a bone on the palatal side and I have a bone on the mesial side, and on the distal side. Same way on the mesial side and the distal side. Means this is a three-wall defect. Means the bone is absent on the buccal side. The bone is absent on the facial side. Okay, so it means it is a three-wall defect. Okay, so if a defect is 3-wall or 2-wall, I would place my implant simultaneously and I would graft it also. And suppose this mesial wall and the distal wall is absent and only the palatal wall is present. So will I place my implant simultaneously and graft it? I won't. Why? Because suppose there is only one wall, that is the palatal wall present, and if I place my implant and I put my graft, so where would my graft get the blood supply and the osteoblast to mature? So the osteoblast would come from the bone that is present there, and the only wall of bone that was present was the palatal bone, and that palatal bone is now completely occupied with the implant that I have placed. So means there is no area to provide osteoblast to my graft to get matured. Okay, and no blood supply also. So the chances that my graft will fail is very high. So please remember, whenever there is a one wall defect, means only one wall on the palatal side is present, don't place the implant at the same time. First do the grafting, wait for 4 months and then place the implant. Okay, but in this case I was lucky enough to have bone on the 3 walls, palatal, mesial and distal. So I placed the implant and the graft. So see what I did, I curated the socket and made a tunnel, and you can see the defect. So I didn't reflect the flap on the buccal side completely. Why? Because this will help to keep my graft in a correct position and stabilize my membrane also, and also will not compromise the blood supply. So the chances that I would get failures with my grafting are very less. So and very one more important point, that the vertical incision for making the tunnel that I gave was at the frenum. So the scar will be completely covered with the frenum and it would not be visible. So the aesthetics, because the patient has high smile line, so I have to look for all those things also. So the facial aesthetics is also not compromised. Okay, so the implants were placed and you can see my implants in a correct position away from the labial plate, and I and you can even see the implant is within the bone envelope. Whenever you are grafting anything, make sure that your implant is not outside the bone envelope. If it is outside the bone envelope, your grafting will not be stable there, and there are high chances that your implant will fail. What is a bone envelope? An envelope of bone coming from the adjacent area. So means my adjacent bone, my implant should be within the confines of the adjacent bone. Okay, so I place my implant. This is the autologous graft that I was telling you I always collect while drilling. So I drill at 100 RPM without saline, and I collect all this autologous graft. So this is a free and a very valuable graft for me. And I mix this graft with a xenograft. Okay. I've secured a membrane. मैंने इसी tunnel से I placed one collagen membrane through the tunnel inside, inside through the tunnel inside, and I just stabilized it below the mucosa. Okay, now what will I do? I'll just push my graft from the I'll push my graft through the socket, and that graft should be collected below the collagen membrane and the implant, in between the collagen membrane and the implant. Okay, so first I push the collagen membrane through the tunnel, and then I push the graft through the socket inside. Okay, then I sutured this tunnel first. So what I did, first I sutured the muscles from inside to the labial flap through a horizontal mattress suture, and then I give some interrupted suture. See the suturing. This is 6O suturing. So you can see this suture. This is a horizontal mattress suture which I passed through the which I sutured the muscles through the labial flap, and then I gave 3 interrupted sutures. And on the top is also double layer suturing. There are 2 horizontal mattress sutures, and rest of the sutures are interrupted sutures. Okay, so this is the post CBCT of the patient. You can see good amount of bone on the buccal side, labial side in this case. Okay, so you can see good. This is 2-1 central incisor, good amount of bone on the buccal side. This is 2-2 lateral incisor. So you can see good amount of bone, around 2.53 mm of bone on my lateral incisor also. Okay, so this is what I want. Whenever I am placing an implant, I want more amount of bone. So for me, a very wide implant is not important. For me, a more amount of bone around my implant is more important. Okay, so see now, how would you do a maxillary premolar and a molar implant? How would you do a maxillary premolar and a molar implant? Okay, see this case. So this this around 28 years girl, she had a failing premolar and with a deep root caries. We extracted the tooth, and we did a socket shield in her. So what we did, we extracted the part of the tooth. This was the part of the tooth we removed. We make the shield properly, and we place the implant in a correct position. See the distance between my implant and the shield. Okay, so my implant is away from the shield because it is the bone that is between this implant and the shield that will stabilize my implant. Okay, so what we did, I got a decent stability, but I gave my patient a temporary prosthesis, and this is the final prosthesis after 3 months that we gave to the patient. Okay, now maxillary molars immediate implant. So what things you have to remember for maxillary molars? A maxillary molar basically has 3 roots. Okay, a mesiobuccal, distobuccal, and a palatal root. And the best part for implant placement in maxillary molar is that the interdental bone in maxillary molar generally is very thick. Interdental bone in maxilla is very thick. Okay, but a point of disadvantage is that there is a sinus above that you have to keep in mind, and also the bone density is thin. Okay, so if I see this, the palatal bone, the mesiobuccal and the distobuccal roots, so this is these sockets, and the interdental bone is quite thick. Okay, so this is a clinical picture. So I would always want my implant to be in the interdental bone. I don't want to place my implant in mesiobuccal, distobuccal, or the palatal socket. Whatever is the case, I will not place my implant in the any of the sockets. Okay, so see how you should proceed for a maxillary molar implant. So this is the mesiobuccal, distobuccal, and the palatal socket, or the palatal roots. So first of all, is the very important that you extract such tooth atraumatically. So don't take a forceps and directly extract the tooth, because while extraction there are high chances that that interdental bone will break and come along with the tooth, and then it is very difficult to place implants simultaneously in such patients. So always section the tooth. How would you section it? I use this long shank carbide burr that fixes in my aorta, and I first section my root, section my buccal roots from the palatal root. Okay, and then I section my mesiobuccal and the distobuccal roots. So it means I'll remove my tooth into 3 pieces. Okay. Next, very important, while you're drilling in the interdental bone, make sure that you don't perforate the sinus membrane. So always keep a probe, blunt probe, to keep on checking that you're not into the sinus. And if you're doing a lift also, you should have this view. This is the sinus membrane, and if you want to do a grafting also, the sinus membrane should be intact. So very important, when you're placing your implant in the interdental bone, you don't perforate your sinus membrane. See, this implant is exactly in the center. We did an indirect sinus lift also in this case, but my implant should be in a correct position. Okay, so the implant should be present interdentally in a correct 3-dimensional position. Okay, so this was a tooth with a which was grossly decayed. We extracted the tooth, and you can see the 3 sockets cleanly. We took a side cutting drill, and I make a punch hole exactly in the interdental papilla, and I drill in the interdental papilla at a very slow speed, same 100 rpm without saline, and I keep on taking x-rays to see how far I am from the sinus. And I place my implant in the center, and I generally don't reflect flap when I am doing an immediate implant, and I don't suture it. So previously what I used to do is I used to take a healing cap and I used to put some flowable composite over it to customize it. Now I have changed my technique. I don't take healing caps, I take abutments, temporary abutments, because what we do when we remove this healing cap, we basically lacerate the gingiva. Okay, but with a abutment, if you're taking, you're not moving the abutment, you're not rotating the abutment, you're just rotating the screw inside the abutment. So I nowadays take abutment and put flowable composite around it and customize my abutment to be used as a customized healing cap. Okay, another case, failing tooth, same, we can see the sockets, and we place the implant exactly in the center in the interdental septum. Achha, one more very important thing when you're doing a maxillary molar immediate implant, that always drill 1 mm less. Suppose I want to place an implant of 5 mm, so my last drill will be 4 mm. Why? Because already the density of bone in maxillary molars is very less, and it is an extraction socket. So if you will drill more, you will not get a primary stability. So I always preferably drill at least 1 mm less when I am placing a maxillary molar immediate implant. Okay, so this is the immediate implant that we have placed, and see how deep you have to place. You have to place same, the basics are same. You have to place it 2 mm below the below the CJ from the adjacent tooth. Okay, don't place it too deep. So these are some of, see, this is so deeply placed, so all this bone will resorb, and to give a prosthesis over this implant is a nightmare. Okay, another case. Okay, this was a referred case to us. Someone placed the implant, and this implant was lying in the sinus. As I tried to put the hex driver over it, that implant slipped inside the sinus. Okay, so what I did, I did a Cadwell Luke. I removed the implant, I repaired the sinus, and I grafted that sinus, and I waited for 5 months for the graft to get matured. Okay, so after 5 months, I opened up the site. This was the graft that was there. I prepared my osteotomy. I placed my implant, and I wait for another 4 months. So this was the implant that I placed after 4 months of initial grafting. Okay, so this is what I want to tell you. You have to decide. In some of the cases, you cannot do immediate implants, so don't try for immediate implants, otherwise you will create a more difficult mess and a more difficulty for you and your patient. Okay, so if you feel like that you cannot get a good stability, like in maxillary second molar, sometimes both the roots are fused. Okay, and the socket is very wide, that it is very difficult to get a good primary stability, because over the socket is the sinus and you cannot get stability even placing the implant deeper. So in such cases, better is to put some graft in the socket and wait for a period of 3 to 4 months and then place the implant in a second stage. Okay, so it is very important that you choose your cases wisely and decide which is an immediate implant case and which is a case in which I have to wait. Okay, another case, failing tooth extraction, immediate implant in the interdental bone. Okay, and I covered the thing with the composite. Okay, so this was a patient in which we didn't place the implant at the same time. The roots were fused and the socket was very big. So we extracted the tooth and we waited for a period of around 3 months, and then we started drilling and we did an indirect lift and we placed the implant in the patient. Okay, another case. Okay, this was a patient who was treated at some clinic and the patient arrived to me in this condition. So in this case also you can see the roots were fused and there was a sinus above and there was a lot of bone defect. So there are chances that I won't get a very good stability and I won't be able to place my implant in a proper three-dimensional position. So we extracted the tooth and we waited for a period of 3 to 4 months. The patient came to me after 4 months. I opened up the side and I had a good amount of bone buccolingually. Now I place the implant in a correct position. Okay, so this is how you have to see, is it a case for immediate implant or not? Okay, okay. Okay, it's the same case. We didn't place the implant. We waited for a period of 4 months. After 4 months, you can see a soft tissue defect on the buccal side. We opened up the area. We gave a papilla preservation flap. We drilled. We placed the implant. Okay. Okay, implants picture is not there. And after 3 months, I opened up the flap again. Okay, and I gave a papilla preservation and I placed the healing cap in the patient. And I rolled my buccal flaps to get a good buccal thickness. I rolled my buccal flap and suture to get a good buccal thickness to cover up that buccal defect of soft tissue that was present. Okay, so this was the X-ray after the healing cap was placed after a period of 3 months. Okay, another case. This was a failing premolar. We extracted the premolar and we placed the implant in a correct position. See the position of implant away from the buccal plate, and I placed a customized healing cap. Okay, so this is after 3 months when the patient came, the healing with the healing cap. I removed the healing cap. You can see the good amount of soft tissue emergence. Okay, you can see a good amount of soft tissue emergence. Now, what I would do, I would take that healing cap. I'll put that healing cap over my analog. I'll take the impression of this healing cap. I'll get a putty index of this healing cap. Now I'll put the impression post over my analog and I'll flow the flowable composite around it. So now I have my customized impression post. This is my customized impression post. I'll put the customized impression post in my patient's mouth and I'll make one impression. And this is the prosthesis that was given to the patient. This is a screw retained prosthesis. Okay. This is the pre and post X-rays. Okay, now a very important thing, short implants that I have very frequently used for my cases, whether they are mandibular molar implants or maxillary molar implants. I use a lot of short implants. Anything that is wider than 5 mm, 6 mm or 7 mm and shorter than 7 mm. Okay, that are short implants. But I use a lot of 6 by 7, 6 by 8.5, even 7 by 6 implants. Means 7 mm is the width and 6 mm is the height of the implant. And what is the rationale for using these implants? Because it has been seen that maximum forces while implant placement, maximum forces on the implant are at the crestal part of the implant. They are at the crestal 4 mm, 5 mm of the implant. So if you're using a short implant, then they work very well. But there are some important criteria while using a short implant. First of all, there should be no off-axis loads. You will never use a short implant for giving a bridge, implant supported bridge. You should never, you should use short implants for single crown, means one implant, one crown. Okay, so I'll show you some cases of short implant. Okay, these are some short implants. These are some short implants. Okay, I've told you the rationale. Okay, so this is a 7 by 7 mm implant. We didn't want to do a sinus lift. The patient was quite old, so we used a wider diameter implant of 7 by 7 mm. Okay, so while placing of implant, please note that undesired angulations should not be given. Okay, so this angulation you cannot expect, your labial plate will be too thin and you cannot expect to give a very good prosthesis over the patient. Your implant is in a compromised condition. So very important to have a proper angulation while placing implant. So very important that you drill in a correct position, you drill correctly. Okay, now mandibular anterior implants. So see, the shape of mandibular anterior in a cross section is something like this. On the lingual side of the mandibular anterior, on the lingual side of the mandibular anterior, we know there are a lot of arteries, ascending branch of sublingual arteries, that if you perforate the lingual plate, that there could be some hematoma that could be life threatening. So very important that you place the implant in a correct, within the confines of the bone. Okay, so what is the correct direction of drilling? If you place this implant, if you drill this implant too labially, the labial plate will get thinned. So if you drill it, keep the drill head too labial, the lingual cortex will get perforated. The lingual cortex will get perforated, and there is chances of hematoma formation. So what is the correct angulation? This is the correct angulation for drilling of and lower anterior implant. So what is to be done? Always keep both your fingers on the, one finger on the palatal side, one finger on the buccal side of the socket, and then drill. Keep your drill resting the palatal wall and drill in the socket. Okay, don't drill towards the palatal wall or towards the facial wall. So keep touch your drill with the palatal wall and drill in the socket. Okay, so this is sublingual hematoma which occurs due to the when injury occurs to the ascending branch of sublingual artery. This is how it looks. If your patient in the evening, in the morning, you have placed an implant. After some time, if the patient comes like this, it means you have perforated the lingual plate, and it is quite serious. If the bleeding is not stopping, the patient can go into asphyxia and could be life-threatening. So you have to check this patient to prevent this bleeding. Okay. Okay, case. This is an interior implant patient. The patient had a road traffic accident and was in, had got root canals around 4 to 5 times, and the tooth were failing. Okay, this was the case. Soft tissue collapse, everything was there. Means this case was high risk patient and very complicated. This was the scans of the patient. All the incisors and one of the canine was failing. So we decided to extract and do immediate implant and GBR. So we extracted the tooth, and this is how the site looked. See the amount of soft tissue, see the amount of bone collapse, and see this thin bundle bone. If I don't do anything, this all bone will get resorbed and will have a thin shelf of bone after some time. Okay, so I drilled my osteotomy. You can see the osteotomy in the palatal bone. My osteotomy is in the palatal bone. So I drilled my osteotomy in the palatal bone, and I placed my implant. And see my placements. My implants are placed away from the labial plate. Okay. Now I need to graft it, and I need to close the flap without any tension. So what I did, I took my blade, a fresh blade, and I did a periosteal release. Means I gave an incision in the periosteum to separate my periosteum and the mucosa. Then I took my scissor and I did some scoring to further release the periosteum from the overlying mucosa. Okay, see, you can see my periosteum is this, and my mucosa is separated from the periosteum. So see in this diagram, I have named it also. The mucosa and the periosteum are separated, and you can see the bone also. Now we'll graft this side. So I collected the bone, autologous bone, while drilling, and I mixed it with a xenograft. Okay, I created some bleeding channels with a round burr, did some decortication, and I placed my graft and secured my collagen membrane. Okay, and this collagen membrane, I'll keep it, this sutures that I've used to stabilize my collagen membrane, I'll leave it for 1 month. I'll not remove it before 1 month. Okay, and see that periosteal release that we have done helps us to gain that good primary closure. So this is the 6O sutures. We did the suturing. This is the double flap closure. We give some horizontal matrice and the interrupted sutures. Okay. Okay, another case. Now this was a lower anterior case, the failing incisors, and there was a soft tissue defect also in this case. So it means I need to address the hard tissue and the soft tissue both simultaneously. So this was the X-ray of the patient. We decided to extract both the incisors, and along with the placement of implant, I decided to do a free gingival graft also. Okay, so we placed both the implants and we did the free gingival graft simultaneously. Okay, so these are the two implants. Okay, so this is all about mandibular anterior implants. Now the last are the mandibular posterior immediate implants. So very important that how you place a mandibular posterior immediate implant. Okay, so see, this was a case in which the mandibular posterior first molar was failing. So generally what we do in maxillary posterior molars, the interdental bone is quite thick. I just showed you also. But in mandibular posteriors, the interdental bone is quite thin. It is not very thick. Okay. So a mandibular molar has two sockets, a mesial socket and a distal socket, and the interdental bone in between is quite thin. Okay. So if we try to place the drill in the center over the interdental bone, so what happens? Quite a lot of times the drill slips, and you basically the drill slips in either the mesial socket or the distal socket, which is not that you want. You want to place your implant exactly in the center of the interdental bone. So if you're placing the drill exactly in the interdental bone, the drill slips either in the mesial socket or the distal socket. So how would you place an immediate implant in mandibular molar? See, I'll tell you. So what I do is, first of all, 100 RPM without saline, I keep my drill in the mesial socket. And I move my drill from mesial to distal. And while moving, what will happen as I move from mesial to distal? I will make a gutter in the center of the interdental bone. I'll make a channel in the center of this interdental bone. Okay, I'm not removing the complete interdental bone. So this is the occlusal view. Okay, so what I am doing, I am moving from mesial to distal, and while I am moving from mesial socket to distal socket with my side cutting drill, I am creating one channel in the center of the interdental bone. Okay, now if I take my side cutting drill and I place my, so see, you can see in this diagram the channel is creating. So I moved from my mesial socket to the distal socket and I created this channel. So now if I place my drill in the interdental bone, this side cutting drill, it will be stabilized with this buccal shelf of interdental bone and the palatal shelf of interdental bone. So my side cutting drill will not now move. Okay, so now I'll put my side cutting drill and the sequential drills, and I will place my implant exactly in the center. Okay, see a case. So a failing first molar, I use the same burr, long shank burr, and I divided the two into mesial and distal, and I extracted it. Okay, so I took an X-ray to make sure it is divided into two, and I extracted it. And this is the interdental bone, which is very thin. So I use the same technique. I took one X-ray to make sure I'm at a distance from my inferior alveolar nerve, and I placed my implant. This was a very old case. I used to graft my immediate also at that time. Now I don't do it if my buccal plate is thicker. So there is no need to graft if your buccal plate is thicker in your mandibular molar implants. Okay, and this is the post-op X-ray. And I close the site with the using the implant mount and the composite around it. Another case, failing molar. I use the same burr, divided it into mesial and distal, but make sure that you don't perforate and don't cut the buccal or the labial plate. Okay, so just cut the tooth portion into mesial and distal and extract it. The interdental bone is intact, and we place the implant in the center. And I gave a customized healing cap also to the patient. So see, I don't give any incision and suturing when I'm doing an immediate implant. So what is the advantage if I am not giving any suture? Because when you suture, you basically create a tension around the tissue and your tissue collapses. I don't want my tissue to get collapsed, so I don't suture in my immediate implants. Okay, another case, I removed my first molar. This is the interdental bone. I use my initial drill and the denser drills to create osteotomy in my interdental bone, and I place my implant exactly in the center of the interdental bone. Okay, see, my implant is not touching any of the bone walls. I placed it 2 mm below the adjacent to cemento enamel junction. Okay, and I placed the healing cap over it. This is the healing cap. Okay, another case, failing first molar, removed an implant exactly in the center. So my main aim to tell you is you need not to place the implant in the mesial socket or the distal socket. It should be bang on in the center, and use a customized healing cap. You can use a soft leg to customize it. There should be no tissue blanching. Keep on removing the excess composite whenever till you see that the blanching over the tissues has reduced. Okay. Okay, another case, failing first molar, we place the implant and we place the large healing caps. Whenever I do a molar implant, I use 7 or 6 or 7 mm width healing caps. I don't use small healing caps. So this provides me a good emergence profile and make good interdental papillas also. So while I give my prosthesis, there is no chances of food lodgement. Okay, so this is the soft tissue healing after 3 months, and we gave the patient a screw retained prosthesis. Another case, a patient with a failed bridge, missing premolar and a failing first molar, but the bone width was very less in the second premolar. Okay, so we extracted it. This was the condition, and we even did the upper implants direct sinus lift in the upper first arch also. So we extracted it and we saw that there is 4 to 5 mm of bone in the lower part. So we did a ridge split. We splitted the ridge. You can see the ridge is split, and we placed both the implants. But in this case, the buccal bone was still very thin. So what we did some grafting on the buccal side, and we secured the collagen membrane with the membrane stabilizing suture. Okay, this is the closer with a double layer closer with a 6/0 nylon. And the upper one, we did a direct sinus lift. Okay, so we created a window in the maxillary sinus to do a direct sinus lift. The window was created 2 mm above the floor of the sinus. You can see I have marked the floor of the sinus, and I created the window 2 mm above it. This is the sinus membrane, and we placed the implant immediately, and the bone height was initially just 2 mm, and we grafted it. And this was the closure that we achieved after the sinus lift. Okay, and this is the post-op X-ray. Okay, so to summarize my presentation today, I would tell you some important things for immediate implants. My drilling protocol is 100 RPM without saline in a clockwise direction for the lens drill and the sequential drills. For placement, I start at very low torque of 25 NCM, and I increase my torque slowly to 30, 35 and 40, whatever is required. Okay, and for mandible in immediate implants, I drill 0.5 mm less, and in maxilla I drill 0.5 mm less. But if the bone is very soft and the socket is quite wider, I drill sometimes 1 mm less. For maxillary molar immediate, always I drill at least 1 mm less. I would like to thank Microlabs for giving me this opportunity to speak on a topic that is very important. And thank you everyone for your patience listening. You can just have ask all your questions. You can just post me up also on my Facebook page, and I'll try to answer them all.
Doctor,
Thank you
there
so
are
much.
questions in the chat box. Two questions in the chat box. If you can open your chat box. Dr. Arun Kumar, Dr. Sakshar, and Dr. Rahul Kumar. Rahul Gupta.
Okay,
Dr. Rahul.
Dr. Rahul.
Dr. Rahul has asked, just a second, I'll just make okay, Dr. Rahul has asked a question, just a second, I'll just get the question. So we can not do a socket shield. Okay, so we can do a socket shield whenever there is a periapical pathology or not. See, if you can remove that portion of tooth and you can remove the pathology also, then you can do a socket shield along with it. How you can just create a semilunar flap and you can create a window and you can remove this pathology, and you can still do a socket shield in such cases. Okay, these are very skillful cases, but you can do a socket shield if there are periapical pathology involved, but you have to completely remove it by giving a semilunar incision at the root apex. Remove all the pathology, create a window, but still it can be done.
Another question from Dr. Arun Kumar in the chat box. This is in the Zoom chat box. The question is, what is your protocol you follow for immediate implant placement in a case where the upper interior
Okay, so the question is depth of burr in mandibular molar for septal bone. See, depth of burr depends when for a mandibular molar implant, when I create a window, so I always use my side cutting drill to create that window or that gutter, so that my sequential drills do not slip. Okay, so the depth will depend upon my inferior alveolar nerve. Okay, ultimately you have to drill 2 mm below the socket to get that primary stability, but please make sure that while drilling there is no nerve, you don't reach quite near to nerve, otherwise the patient will have paresthesia. So depth will depend upon the location of the inferior alveolar nerve. If the buccal bone has resolved after implant placement after 6 months, okay, see, if the bone has resolved after 6 months, then obviously you have to reflect the flap. If the bone is there on the 3 walls, on the palatal wall, mesial wall, and distal wall, you can graft that site, you can place a membrane, but you have to submerge that implant for another 3 months to get the bone on the buccal side. Okay, so these are difficult things, but you have to do the grafting and then wait for another 3 to 4 months to get that bone on the buccal side. Okay, what is your protocol you follow for immediate implant placement in a case where the upper interior tooth avulsion happened 10 days back due to the trauma? So I treat it like an regular immediate implant. So after the tooth avulsion, if the socket is intact, it is like an immediate implant. I have extracted the tooth and I have placed my implant. If suppose there is a trauma and the labial plate is fractured, then I need to do the grafting also for the labial plate. Otherwise, it is like a normal immediate implant which I am doing for my patient. Okay, how do you overcome the comet fear from the patients? Do perceive it as a challenge present situation? Okay, so present situation is obviously very challenging for all of us, whether it is dental implants or regular dentistry. But I believe personally that it is all see, the patients are very fearful, but if you're taking all the precautions, you can practice dentistry very safely. But very important that all the precautions, whether it is disinfection procedures, your safety procedures, your patient safety procedures, everything should be taken care of without any small glitch also. Okay. Okay, by mistake, if tooth fragment came out during socket shield, can we put it again? No. If during socket shield your fragment of the tooth is mobile or it has come out, you cannot do a socket shield. Just remove it and do it like an immediate implant. So if your shield is moving or if your shield has come out, if it is slightly mobile also, don't leave that shield there. Just remove it and treat it like a normal immediate implant. After how many days of extraction of tooth can we place an implant? See, generally, I told this, my whole presentation was on immediate implant today. If you can place an immediate implant exactly after the extraction of the tooth, it is the best scenario because you basically preserve the amount of bone. If you cannot do it, you can wait for 3 months, let the bone heal, let the initial woven bone form, and then you can drill and place the implants. So if you want to delay it for 3 to 4 months and then place it. In premolar socket shield technique, if jumping distance more than, see, if it is more than 2 mm, I personally don't graft it. Okay, if I have got a good primary stability while doing a socket shield in my premolars also. Okay, like I showed the case that distance was more than 2 mm, I didn't graft it. But it is recommended if the jumping distance is more than 2.5 mm, you generally should graft it. Okay. Protocols and difference between a normal immediate implant placement and an implant to be replaced with a tooth with pathology. Okay, normal immediate plan. See, whenever there is a pathology, okay, so by pathology, I mean two things. First of all, if the pathology has not resorbed the labial plate, it means there is a periapical infection. What I do is I just pull out my tooth, I curate my socket nicely, and I place my implant there. Okay, but make sure that there is no granulation tissue that is left inside the socket, and irrigate nicely with a normal saline. Use 100-200 ml of saline to irrigate your socket. So this is a case when the labial plate is not resorbed due to the pathology. But in case when your labial plate is resorbed, then you have to do a GBR or a grafting. Like I showed you a case in which a labial plate was resorbed and I grafted the labial plate. With the graft and the membrane along with the implant placement. And I even told you, in this pathology, if the 3 walls are intact, means there is 3 wall defect. The walls are present on the mesial side, distal side, on the palatal side. Then you can basically place the implant and graft at the same time. But if only the palatal wall is present, mesial, distal, and the buccal walls are absent, then just graft the side and don't place the implant at that time. Wait for 4 months and then place the implant. Okay. Okay. After Wilson case, you are planning after 3 days. Then why not in extraction case we can do it? See, it's up to you. You can do it in after 3 days, 5 days, 7 days. But there is no such criteria. You can even place an implant after 5 days, 7 days also. But why to give a patient trauma of 2 times? Why to do a surgical procedure 2 times? When you are anesthetizing your patient for an extraction, I always prefer to place an implant at the same time. Okay, so you're extracting today and then you're calling a patient after 3 days for placing an implant. There is no harm in it. You can do it. But why to go give a patient a double trauma of 2 times anesthesia and 2 times surgery? I hope I am clear. If due to any reason implant cannot be placed just after extraction and patient wants to be done within few days, it can happen. Patient failed to come after 3 months. Okay, so you can place your implant after 3 days. You see, it's not necessary that you're doing your immediate implant. If you are not doing your immediate implant, I told you type 2 implants are when you place your implant after 4 to 6 weeks, 4 to 8 weeks also. So you can even place your implant after 7 days of tooth extraction. That is not a contraindication. Okay, so you can do it after 10 days, 15 days, 20 days. But when you have extracted the tooth and you have not placed it at the same time, I preferably would advise you to wait for 10 to 15 days to get a good soft tissue closure. Okay. Okay, I always use 6O sutures and I always work with loops. I use 4x magnification of loops while doing my general dentistry and my implant dentistry. We talk about to preserve buccal plate. Okay, I told you in my initial slides, the facial or the buccal plate is very thin. The plate thickness I told you one of the studies also is less than 1 mm in 70% cases, and in very few cases it is around 1.25 mm. But on the other hand, the palatal plate is very thick, 4 mm, 5 mm. And also it is attached with a thick keratinized tissue that provides a good blood supply to the palatal bone. So very rare chances that the palatal bone will resorb and the thickness will reduce. And also, if you will study the bone resorption pattern of the mandible and maxilla, it always starts from the buccal side. It never starts from the palatal side. So you always have to take care of the facial of the buccal bone, which is already thin, and there are a lot of resorptive factors that starts occurring when the tooth comes out. Okay, mini implants or short implants you want to ask? Mini implants or short implants? Okay, I guess you're asking about short implant. See, short implants are advantageous because, first of all, short implants, if you're using, what is the rationale for using a short implant? So we are using a short implant that is quite wide. I would never use a short implant that is 4 mm in width. Okay, for a molar, I would use a short implant that is at least 5, 6, or 7. Okay, so what happens as the width of the implant increases by 0.5 mm? As the width of the implant increases by 0.5 mm, the surface area of the implant increases by around 15%. Okay, so if your implant width is increasing by 0.5 mm, the surface area is increasing by 12 to 15%. As compared, if the length of the implant is increasing by 1 mm, the surface area only increases by 2 to 3%. Okay, so for me, if the width is increasing more, then the surface area of my implant is getting more. So more surface area, more integration with the bone. More surface area, more integration with the bone. Okay, so suppose I am using, this happens mostly in mandibular second molar because the nerve position is quite high. So I don't get that height of bone to place a 10 or 11.5 mm implant. So generally I am placing a 8.5 or a 7 mm implant and sometimes a 6 mm implant also. Same as with maxillary molar. The sinus is quite pneumatized sometimes and you cannot place a very wide implant. Okay, and sometimes I told you that both the buccal and the palatal roots are fused and the socket is quite wider. You cannot get a good stability with a normal 4.5 or 5 mm implant. So in such cases, I use a wide implant of 7 mm sometimes. I can show you a case of 7 by 10 mm implant I have placed a couple of weeks back. I was not getting a good stability with a 5 by 10 implant, but I get a good stability by 7 by 10 implant. So these short implants and wide implants helps you a lot. You should always keep it in your armamentarium, especially when you're doing mandibular or maxillary molar implants. I guess I have answered all the questions. If you have any other questions, you can ping me out on my Facebook by name of Dr. Kapil Singhal.
Thank you, doctor. That was really a rocking session by you. You really rocked and absolutely very patiently answered all the questions. Almost 1 hour, 40 minutes continuously you took, and I think rapt attention by everybody. Thank you so much, and thank you for everybody for attending this today's evening session, which you definitely must have found it very, very interesting. Thank you, one and all, and please take care.